3D printing technology is pushing the limits of customization, bringing ease to surgical planning and making predictable outcomes. If you are a surgeon wanting to make lives better, you are in the right place. Welcome to the Surgeons in 3D Printing podcast. And now, your host, Dr. Ruchi Pathak Kaul, to take you on this beautiful journey.
Welcome to the Surgeons in 3D Printing podcast. And today I have a very special guest and a distinguished surgeon with a very distinguished career in both academic and clinical research. Welcome, Professor Dennis Rohner, on the Surgeons in 3D Printing podcast. And
welcome. Thank you.
Sir, I see that you've done your hand surgery, then general surgery, then orthopedic surgery, and then maxillofacial surgery. Now, these are different areas. People can barely do one and then So then finally you chose to get into like the maxillofacial surgery area where you did the fibula, and you worked so much on that one. And you're a pioneer, as I said, you're a pioneer who gave to the world the concept of fibula guides and prefabrication of fibula. So having said all of that, I would like to start and begin with how come so many different specialties and then coming down to one? What led you to that?
So thank you very much for this invitation to speak to you and speak to everyone here who's listening. We in Switzerland, to become a maxillofacial surgeon, we have to study dentistry and medicine. So that means about 9 years university, and then we start with our specialization. And before we start with maxillofacial surgery, we have to go through general surgery or some kind of general surgery, and that's what I did. So I just we have to look for a hospital that will be able to apply for you, and then so I did 1 year of hand surgery just because it was free, and it was absolutely fantastic to learn this kind of surgery. Then I went over to general surgery and then to orthopedic surgery because I wanted to go to the University of Basel to become a maxillofacial surgeon, and that at that time there was no position free. So that's why I just moved over to orthopedic surgery, because I wanted to do some surgery with bone. And so at the end, I was happy. After 4 years, I was happy to get the position as maxillofacial surgeon at university in Basel, and so I became maxillofacial surgeon. So the other specialties was kind of just because I had to wait before I got the position as maxillofacial surgeon. But at the end, I was very happy to go through all these specialties because I learned a lot, especially in orthopedic surgery, of course. So that was a reason that I was not afraid of harvesting a fibula flap, because I was used to work with the fibula bone. But from that point of view, and another point of view was that during my medicine university time, I worked as dentist as well. So part time, just to get money to finance my university. And so I learned also to deal with dental patients with their problems, with the prosthesis, already with the patients that had defects, and how did they suffer from these defects? And that was the beginning of my journey, so that I wanted to become a maxillofacial surgeon to treat these patients that have so many problems with their oral function.
Wonderful. And then, as I said, that you gave the concept of fibula guides. So what came to your mind, and what was the surgery that you were involved with, and how did that come about?
So at the beginning, when I started with maxillofacial surgery, it was the start of the free flaps as well. So in these times, so the maxillofacial surgeons, they started to harvest free flaps. It was not very well known. And so we did some of these fibula flaps without any implants, of course. And then we saw that at the end, so when we did the fibula flap and we did the reconstruction, somehow it didn't fit at the end, because we didn't have any kind of orientation how to position the flap and so on. And at the end, even if the defect was bridged, it was not a benefit for the patient because there was no clue or no good situation to insert some implants. That was the point when we thought back to our dentistry time and we said, okay, finally we have to find the perfect position for the occlusion. The perfect occlusion will be in that way, and so where should be the implant, where should be the bone, and so on. So we started just to think back from the occlusion back to the defect, and then we started to find out, okay, it would be much better first to define the occlusion and then at the end define the segmentation of the fibula and where should the position be. So that was kind of, because we're double degreed, so we think also as dentists as well as surgeons, we could combine these knowledge, and that, I guess, this is the main part. Because I spoke with quite a few plastic surgeons that are doing a lot of free flaps, and they don't have a clue about occlusion. They said, I don't care about occlusion. I just want to reconstruct the defect. That's all, and then I'm happy. But at the end, maybe the surgeon is happy, but not the patient. And that was the point where we started to really think different.
Right. So with this, I'd like to ask you a question. So if I take you a little bit backwards, so while you were doing those surgeries where you were basically rehabilitating the defect with the bone, what was your success in terms of you finding success in terms of what you've done? Like you said, you couldn't give the patient teeth. Actually, the patient was not getting the teeth. Only the gap was being bridged. You did have implants, but then you didn't have the exact positions. Like you didn't have anything which is called as surgical planning at the moment. So what did you call success at that time? Because it's been quite a while.
Yes, it's difficult to say because, at the beginning we were already happy just to reconstruct the defect with the free flap, and the free flap survived. Because at the beginning of these surgeries, we had quite a high, so everybody had quite a high failure rate, and so we were already happy if the flap survived. But then, from a certain point on, when we saw, okay, so if we do the surgery correct and the anastomosis as well correct, so then the flap survives absolutely smoothly. But then the next step is, now how can we do the reconstruction for the patient that he can really chew and he can really smile and he has a correct prosthesis that is fixed. And this was the point where we started, okay, now we have to change something because it doesn't work really. And also the other thing is, it's not only the question of the bone, it's only the question of the soft tissue. So how can we reduce the soft tissue? Because if we just take a flap together with a skin island, so we have quite a bulk in the mouth, and the patient is talking like that because he has a closed defect, absolutely, but there is no function and there is just too much of soft tissue. So that was the other point that we said, okay, we have to reduce the soft tissue down to a thickness that is comparable to gingiva, which is very difficult to get. Okay. So that was the point also that we said, okay, thinking back to our fathers in maxillofacial surgery, they did quite a lot of vestibuloplasties using skin grafts. And then we thought, okay, doing a vestibuloplasty means we have just to have a bone and we have periosteum, and then we have to cover this bone and periosteum with a skin graft. Okay, why can't we do that also with a fibula? Because the fibula is the bone, has a periosteum, and we just cover it with a skin graft. And that was then the point where we thought, okay, so now we have the vestibuloplasty, we have implants that we can insert, we can do the planning, and then we can combine everything. And of course, that was let's say, at that time when I was at the university in Basel, I had a perfect and absolutely amazing head of the department who allowed me to do that. So because a lot of other chiefs, they would say, hey, you are stupid, don't do that, we are not dentists, we do it differently. I was really able to invent this technique and also to do that with patients, and then we saw at the end, wow, the results were really fantastic and amazing. And it gives us a much better result than compared to the older techniques. That was my journey.
Right. So right now, do you start from the occlusion and from the functional aspect and then go back towards reconstructing the bone actually?
Yeah.
So reverse planning.
Yeah, exactly.
Reverse engineering the defect entirely. So do you have a orthodontist on roll with you while you're working as a team?
Yes, we have within our office, we have a dental technician who is doing a lot of work with us. So in the past, of course, we did everything with plaster cast models, and nowadays we are doing more and more with digital planning, of course, because all these tools are available, and we can now do that with all these different software products, which makes it much easier, of course, and also faster for the planning part.
Right.
But,
so because
but you need a technician that is really into that work and also understands what you're doing.
Right. So in your time, virtual surgical planning was not there. You were the one who actually initiated that part. So I'd like to ask you, what are the problems you faced? Because if that was something that you were thinking of, while other surgeons were not, so you would have to convince a lot to many more people to be able to do that and to prove that what you're saying is doable. So what were the kind of difficulties you faced there, and how did you counter them?
Yeah, so the first thing was that we operated on some patients, then we had the good results, and then we started to present it on international conferences. So we just went to different conferences and we showed our results. At the beginning, it was kind of smile from the others. They said, "Yeah, that's a few patients. That was maybe a happy result." But in general, we don't do that because it's too difficult, and we have different patients. So that was a lot of time. It was this explanation from other surgeons. But then more and more the awareness came that this is really an interesting thing. And then I started to give some courses and also to convince people to start with that technique as well. And so more and more countries and more universities started to do that. But of course, at the end, it's a personal, let's say, they have to be convinced that this is a good technique. And then they start to do that. And of course, they have to have some kind of, or they have to be open to dental, and they have to be dental minded as well. Otherwise, they don't care about anything.
Yeah. And then you gave a concept of a jaw and teeth in a day. I'd like you to talk about that one.
Jaw in a day is not my concept. That's not my concept. That's a concept from so let's say I went to New York and I gave some lectures about this prefabrication, and then the group in New York, they took over. And they somehow remodeled it to the jaw in a day surgery. But it's kind of our concept, but it's with the different perspectives that they are doing.
Okay, so then I would like to ask you about your journey on prefabrication integrated care. Like, how do you prefabricate and give the implants for the fibular, for mandibular reconstruction, and the role of integrated care in the entire journey of that process?
Yes, there are different patients. So some are patients that have a cancer at the moment, and we have to resect the cancer. We don't have time in these patients just to wait for a prefabrication, of course, because it will last a few weeks. From the prefabrication to the resection part, which would not be acceptable for a tumor patient. But we have quite a few patients that suffer from osteoradionecrosis after radiation therapy 10 years, 15 years ago, and these are the perfect patients for prefabrication, because we have time to do the planning, we have time to evaluate how do we reconstruct the occlusion and so on. So we have enough time, and then we can do the plan. So, and then of course we have also these patients with benign tumors, but with recurrent benign tumors like amyloblastoma, which is a typical tumor. that regrows and destroys the bone, and at the end you have just to do a resection. And also in these patients we have time to do the planning. And these are also mainly younger patients that are really that are really suffering if you would just do the resection and you don't do any kind of really good reconstruction. So these are the patients. So what we do is, of course, we just sit together with them and discuss everything. We show them cases, we explain them how to do that and so on. And even if they know, okay, we have to go through different surgeries at the end till the end, but at the end it's successful, and they see, okay, it gives me a lot of benefits for the future, which is not only for the next 5 years but for next 20 years. And this is then the point where they say, okay, let's go through that.
Right. So what do you think about the team's role? Like, as I said, the entire team and working in collaboration to get this done. So who do you think are important people who should be in your team?
Absolutely the technician, the dentist, so the prosthodontist, then the surgeon, of course. So we have to discuss what is the expected occlusion, how can we fix the occlusion, what is the opponent occlusion, can we fix that, is it a prosthesis, is it mobile, is it fixed, how can we reconstruct the defect, what is the extent of teeth that are missing, how many teeth shall we reconstruct, how many implants do we need, and so on. So this is a discussion that goes through in between the prosthodontist or general dentist, and then the technician and the surgeon, and of course also the patient, because the patient at the end has to say, okay, do I want to have a fixed bridge or a removable one, or what is my expectation?
Right. So and then, because you said that you offer training programs as well, I'd like to talk about cross-border collaboration. Like, how do you feel about that? Because there is a training program that you'll be a part of sooner, I think, with Dr Srinivas.
Yeah.
I would like you to talk about that, your preparations for that, and how are you planning to mentor the younger generation on that?
Yeah, that's so based on these digital tools that we have now, we can have quite a lot of podcasts, web meetings, and so on, where we can discuss cases. I guess this is a big advantage of the today situation, so that we do not have to travel a lot. Of course, we plan also that we maybe do some surgeries on 1 or 2 patients in India, and have an on-site course. How does it work, and how do we plan? But the main part will be on web meetings, and also on written, or let's say on slides, on PowerPoint presentations, and so on, where we can explain step by step how it works and so on. Of course, at the end, it's as you said, a kind of teamwork. So even if people in India would like to start with that, so they have to kind of assemble a team that is really going through this. And as I know, sometimes it's difficult because the plastic surgeons in India are not so open to these kind of techniques, and this will be at the beginning maybe a bit the stumble stone that could hinder the beginning of such a process. But I guess the team, as you said, the team is very important, that all the team members are really focusing on a better treatment for the patient, better outcome for the patient.
Yeah, we look forward to seeing you in that program, and we look forward to hearing from you what you have to say and sharing what you've had in your expertise for so long. But I would like to ask you for what is your larger vision in terms of spreading to the world, spreading your word, not only to India but to the world, regarding this kind of surgeries.
So, one of the main reasons that I'm doing this surgery is that I see patients that are really suffering from their disease, whether there is a tumor disease or whether they are suffering from any kind of scarring, and they have not a good oral function, not a good swallowing, not a good life quality. And at the end, I think it's for a lot of patients, it's not as important to be tumor-free as it is important to have a better quality of life. And some of my patients that had radiotherapy 20 years ago or 15 years ago, they are really suffering, and they say, if I knew I wouldn't have go through radiotherapy, better to have a good reconstruction and then a good quality of life for, let's say, next 10 years. Maybe then I will die. But at the end, it's better than to have a reduced quality of life and I'm still tumor-free, but I don't care because I'm suffering every day due to the radiotherapy. And I guess this is what I like to do, is just to discuss with the patients and to see how do they feel, what is really their expectation, what do they want, and then based on that I will define the treatment. I don't tell them you have to go through that or through that, so I just give them all the options, and at the end they have to decide on their own, together with the family, together with the other people, but they have to take the decision and not we.
Yeah, so basically like working more on the functional aspect and more on the expectation aspect of the patient, rather than just being ready to reconstruct the bone and just get things going and just starting so early and not even understanding what the patient has to say.
Yes, yeah, exactly.
That's wonderful. We look forward to seeing you in India, and I would ask my listeners to actually go enroll on the program and be there for people like yourself, experts like yourself coming here and actually teaching these things. Yeah. So thank you so much for being in this podcast. In the end, I would like to ask you, are you there also in some sort of sport?
Yes, so I'm just in 1 week I will just go up to the mountains. As Swiss, we have to go for skiing, and I will have 2 weeks of holidays for skiing. And
I was wondering. That's why I asked you. That's the best time to go, actually.
Exactly. Yeah.
Okay, so your skiing begins, and then thereafter you'll be here. Sometime. Wonderful. Well,
yes.
It was a pleasure to have you on this platform. Thank you so much.
Thank you very much. Thank you very much, Ruchi.
So see you next week once again with another episode of Surgeons in 3D Printing. Till then, stay safe and live with passion.